quick ride through everything you can see in different pacemaker devices from different companies, and it's pretty difficult because, first of all algorithms, markers, and timings are a little bit different. And finally, also we have the good old ECG. That is what I personally love very, very much. I was making sure that all doors are locked so nobody can go out even if it gets much too fast and too difficult. The rooms are locked, so you have to stay inside a half an hour. So if there's one thing I would love is that after this course, when you go home and do your clinical practice in everyday life, you will never ever make an ECG interpretation of pacemaker ECG, 60 beats per minute, full stop. That is what I see sometimes, and it is like you do a coronary angiography and you say, we detected 3 vessels, stop. So if you interpret ECGs and pacemakers, and that is the key to understand how they work, how you can improve problems of pacemakers, please stick to the general rules how you interpret every normal ECG with or without pacemaker. That is, look at the basic rhythm, can be atrial fibrillation, sinus rhythm, atrioventricular pacing, or both. Look at the QRS axis, also with paced QRS. Look at the intervals. You saw some funny intervals where some pacemakers were suddenly having a long PQ and before a short PQ. This is obviously interesting. Look at the morphology and irregularities. Particularly look at pacing spike and what is happening after the spike. A P wave, a QRS complex, is the spike to signal distance always the same or different? That is the key to understand pacemaker ECGs. So systematic analysis on top, check typical arrhythmias. Number 3, check typical pacemaker algorithms if you know them. And finally, check typical pacemaker malfunctions. And this I will go through very, very quick because I have only 30 minutes. What are typical arrhythmias? You know all different funny arrhythmias that are possible in every human being, also in pacemaker patients, and please look at them because they are sometimes overlooked. Then typical pacemaker malfunctions are only 3 for each lead. Undersensing, oversensing, exit block, or loss of capture for the atrium, for the ventricle, and if you have it, for the left ventricle. So, and then typical malfunctions, again, can be seen. We've had this enough. I think I can skip it. Always look again, this is the second time I mention it, please, at the distance between pacing spike and P wave, or pacing spike and QRS. And also, if it's a dual chamber, distance between P wave of the patient to next pacing spike, and then you can understand if it's undersensing, oversensing, or anything else. Again, these are the 6 problems. There are either too many or too few paces. So that's the key. And finally, these are the algorithms, and somebody was asking before, that you should know, I think, to understand the normal general behavior of pacemakers. Mode switching, going from tracking mode to non-tracking mode. Rate response by sensors. Rate adaptive and otherwise changing AV intervals, also newer algorithms. Things like PVC reaction or pacemaker-mediated tachycardia intervention, safety window pacing, we've seen already, and maybe magnet reaction. There are some more, but these are, I would say, the basic things. And so again, if you look at pacemaker ECGs, look at the normal ECG interpretation, number 1. Check arrhythmias, number 2. Check the pacemaker spikes, are they there? Or are some pacemaker spikes you're looking for are not there? And then if you still don't understand the ECG, go through these 7 algorithms. Could it be any of these? So that's the first ECG. I don't have questions because I knew we will never manage this with 45 seconds for you to check A, B, C, D, E. But I think if we go through all together, everybody will notice that on the left side of the ECG, the rhythm is regular, around 60 beats per minute. And on the right side of the picture, it is still regular, but much faster, around 120 beats per minute. So the interesting point is what happens between here and here. or what is the arrhythmia, the tachycardia at the end? So, whenever the pacemaker is pacing inappropriately fast, this is always pacemaker-mediated tachycardia. Also, when you have atrial fibrillation and this is tracked at 120 beats per minute, this is also pacemaker. So it's a very clever answer, because when it's fast and you see pacemaker spikes, it is pacemaker-mediated. Wonderful. It doesn't tell you the complete mechanism. That's what I would love to hear from you. So, okay, wow. So again, this is the third example you see in this course. This is maybe not very representative, but it's good because the more you repeat it, the better you know it. And I love this ECG because this is the ECG which is the best I've ever seen for retrograde P waves. You see them here, right? The retrograde P wave should be looked at in lead Roman 2, ideally, and it's very clearly visible. So it's like a WPW, ventricular excitation, retrograde conduction through the AV node, integrate through the pacemaker like accessory pathway. Okay? And now already I've heard the mechanism. Why does this patient suddenly develop endless loop tachycardia, pacemaker-mediated tachycardia? If you just repeat, yeah, some of you folks saw maybe even from behind, I don't know if it's visible, but maybe this is the only paced P wave that is visible from the end of the room. At the beginning, you see it here in Roman 2, atrial spike, P wave after it, here no longer, and already you see a retrograde P wave, which is so early that it is still in the refractory period and doesn't trigger here PMT. Again here, and then the retrograde conduction gets slower. The AV node is a little bit exhausted, and now it is so slow that it is outside the refractory period, and it is sensed by the device and tracked. So that is very nice to see. Intermittent loss of atrial capture, retrograde P wave conduction, and finally endless loop tachycardia. Extremely good. If that was too fast for you, that is normal, because that was really fast, and I think the best are of course the fastest, and could be a little bit difficult. So some causes for endless loop tachycardia, any PVC with retrograde conduction can trigger it, any SVC or atrial premature beat can trigger it, because there's then maybe asynchronous ventricular pacing, myopotential oversensing can also trigger it. So there are a number of causes for ELT, endless loop tachycardia, one form of pacemaker-mediated tachycardia. Very, very nice. Now, this is a very, very funny ECG. One of my fellows was showing it to me and said, whenever I make a ventricular or atrial threshold test in this patient, he gets very, very dizzy, and I don't like the ECG, but I'm not sure what's going on. So this is the start of the atrial threshold test. Here you have 0.75, oh no, you have sensing, and then pacing, and then it's very nice of that guy to stop it here. And then I took over and made the same, and I was a little bit harder to the patient. He was lying down, so he can't drop down. And I made a programmed atrial pacing test, atrial pace, P wave, atrial pace, P wave. Maybe some of you will notice something is missing. If you do daily pacemaker controls, it would be nice if you see that there's something missing and you stop what you're doing, because this is harmful. What could be the reason? AV, no? This is something I hope you will never see, but it can happen at least during testing, and it can happen in some older devices. What is here, we all know here should be a ventricular pace, right? It looks a little bit like this patient has an AV block. So he will not have a QRS himself. It would be nice of the pacemaker to help this patient in this situation, but the pacemaker doesn't do it. Why? Only one reason? Oversensing, yeah. If there is no ventricular spike, and there should be one, this is oversensing. Why on earth does this pacemaker always oversense when there's atrial pacing and not when there's atrial sensing? The pacemaker is inside already half a year. No lead dislodgement. Wonderful. Crosstalk. This is the real good old crosstalk. It is clear whenever the atrium is not paced, the ventricular gets his nice ventricular pace. As soon as the atrium is paced, there is no more ventricular pacing. So obviously the atrial pace is sensed by the ventricle. And this is obviously quite life-threatening. And here you see, in fact, atrial pacing an A, and at the same time, ventricular sensing an R. So that is the proof. This is ventricular or crosstalk. Atrial pace is sensed in the ventricle, and this could, of course, lead to death. And that is why all modern pacemakers have a ventricular safety pacing feature, and that is nominally on in almost all devices, which is a good idea, by the way. This is not so nice, but again, there's atrial pacing. It could be that in some old leads, whatever, some of the current is still visible at the end of a safety window in the ventricle. And then the pacemaker says, okay, nobody can conduct within 120 milliseconds or something like this. So this is maybe oversending crosstalk. Let's better pace the ventricle. And it's a good idea. And this is appropriate safety window pacing. And of course, we have also frequently inappropriate safety window pacing. Why do I say this is safety window pacing? This is a 1 second diagnosis. No, it's not switch. Leads are, sometimes we look what we fix where. Yes, very, very good. Somebody said that you have 2 spikes here and 2 spikes here. And obviously the difference is these spikes are very close to each other, 110 milliseconds, and these spikes are much more apart, 180 milliseconds. And I can assure you, we were not reprogramming the device in between. So this must be an automatic algorithm. There's no other way. It must be automatic. If you program the paced AV delay to 110 milliseconds, you didn't listen to some of the speakers who are trying to teach you that you should not use short AV delays because you should avoid unnecessary ventricular pacing. So if you have programmed this AV delay, you didn't understand the course completely and should repeat it. So this must be an automatic algorithm. Why is here safety window pacing? Atrial spike, QRS, ventricular spike. What is the basic malfunction of this device? I've heard it already. So if you go through systematically, number 1, what's the basic rhythm? Somewhat to see. Difficult, yeah, some would say silent is very difficult to see. It's irregular, but it's not easy to see. Atrial fibrillation. You should click atrial fibrillation is frequently undersensed by devices. So there is atrial pacing where it should not be, atrial undersensing of AF, atrial pacing, and frequently this atrial pace is then just at the moment when atrial fibrillation has spontaneous AV conduction. So this happens frequently. So inappropriate ventricular safety pacing should always remind you of atrial undersensing. Here, atrial undersensing of AF, which is frequent. I think there should be some more pictures on this. Here you see it. Here you see better that there's atrial fibrillation. This is the atrial electrogram with lots of fibrillation. And here you see this funny behavior, spike, QRS, spike with narrow AV. That's the typical situation. And down you have even what I love very much in older Medtronic devices. You see that there is this so-called ladder diagram. This is how the device thinks. And even it tells you here safe. So inappropriate ventricular safety pacing, atrial undersensing, typical cause. And you see here, the nice thing is that this ventricular pace is never really dangerous because it will always be in a refractory phase. That is why it's so short. If you program an AV delay of 350, could be somewhat more difficult or dangerous. ECG number 4. Oh wow, that is really bad. I was called to the intensive care unit. This was a patient on dialysis, heart failure, kidney failure, and somebody said, I think somehow this ECG looks funny. So very, very difficult. What I want to remind you, systematic. What's the intrinsic rhythm? What's the pacemaker doing? And so forth. What's the intrinsic rhythm? Patients on intensive care sometimes are not friendly. They move. So ECGs are not so nice. So this is a real life example. Is anybody in the room who sees a nice P wave? That is already 50% of the diagnosis. This is a rhythm without a P wave. Is the intrinsic rhythm regular or irregular? In fact, it is very regular. I'm not sure if you can take calipers on your printouts. They're a little bit small, but I just tell you this is regular. So intrinsic rhythm, let's say about 70 beats per minute. Regular, no P wave. Also, to be honest, no fibrillation or flutter waves. Any suggestion? AV junctional escape rhythm. And renal failure patients with potassium of 5, 6, or 2, like all types of these kinds of arrhythmias, so that is frequent. And dual chamber devices do not understand at all an AV junctional rhythm, because in an AV junctional rhythm, the A and the V are sometimes at the same time, sometimes the A before the V, sometimes the V before the A. So this is a VT, is an SV rhythm, or I don't know, for the pacemaker, and this is what it makes out of it. Atrial pacing is almost at the same time as ventricular intrinsic rhythm, and so there's always here, what do you see? It's easy, we had it. So that is the longest period of consecutive ventricular safety pacings that I could show you. And it's good that somebody was somehow puzzled by this ECG and had the feeling this is not how it is supposed to be. Same patient, I just skip it. You see again long and short. So here, the atrial pace is a little bit too late. So the ventricle QRS is in the complete blanking period. It's not sensed. And here's the ventricular spike at a normal AV delay. Here, the ventricular is somewhat different. So it is sensed after the atrial pace. And here you have an example where the ventricular is a little bit faster than the atrial pace. So you have in AV junctional rhythm, you have very, very funny looking ECGs. But the patients maybe not like this too much and not find this too funny. So the solution, increase beta blockers and increase the pacing rate. 80 beats per minute, overdrive the AV junctional rhythm, and you have a wonderful, absolutely normal ECG. Even no unnecessary ventricular pacing. That is something I see sometimes in patients with CRT. CRT devices do not understand at all AV junctional rhythm. They do not pace, or if they pace, they make very stupid things. So again, program higher, make an overdrive, then you have normal AV sequence, which is helpful for the patient. This is too difficult. I'll skip it. It's big fun for me, but maybe not for you. This also. This is just so this is very funny. I'm not sure if anybody understands this. This is what happens sometimes in my patients. So first of all, it looks like a perfectly normal ECG, and you may wonder why I show it to you. Why do I show it to you? Remember, this is troubleshooting. So some say systematically the rhythm, underlying rhythm, atrial fibrillation. Wonderful. Okay. But that is not yet a pacemaker malfunction. What is the pacemaker malfunction? It looks like undersensing. Here on the right side, you see there's in V1, nice big flutter or fibrillation waves, and still there's atrial pacing. So, undersensing of atrial fibrillation. That would be boring. I show you the marker, and here is the atrial flutter or fibrillation rather. And you see hundreds of markers. Every single fibrillation wave has been sensed. And even the device says it is in automatic mode switch, AMS. And in fact, to be honest, I always program my devices to very high atrial sensitivity, 0.2, to make sure that atrial fibrillation is always detected. I don't want this in and out. No, I don't want that the device tells me there are 46,000 episodes of atrial fibrillation of 12 seconds each, when I know it's 3 months atrial fibrillation. So that's why I program them very, very sensitive, 0.2. Any idea, if you know what's the cause, why does the device see all fibrillation waves, performs mode switch, but still performs atrial pacing? If there's anybody who knows this, he is wrong in this course, because then he's a real expert. I think I've heard the right answer. As soon as you see that the sensed events overlap each other, that means here every sensed event triggers a short period. If the device has the next atrial sense within this short period, again and again and again, until, let's say, 1 second, it says, okay, this is continuous sensing. I sense for 1 second, I sense all the time, and this may be noise, electrical noise in an MRI, electrical noise, whatever. And then the device has a noise reversion mode, typically, which is DOO. That means atrial ventricular pacing, even despite the fact that everything is seen. So this is just an example. Go through intrinsic rhythm, pacemaker behavior, and then that is mean, know all the algorithms. And that would be algorithm number 11. That here is the schematic view. When you see for a complete interval, a complete timing cycle, all the time, again and again and again, sensing. This sensing is continuous for the device, and it says this is noise, not a biological signal. I'll skip this. It's funny, but a little bit embarrassing. And I have one more topic that I like very much. This is, to be honest, a very boring ECG, right? Dual chamber device. Atrial pacing, correct? Effective? Yes. You see a P wave after each atrial spike. The P wave is always at a regular, similar interval after the spike, so it's not just coincidence. The sinus rhythm is never the same. It always changes a little bit. Pacing is exactly on the millisecond the same. So if you want to know, is this coincidence or is this paced, you just look if all the spike to P wave distances are the same. They are the same, so it's no coincidence. Atrial pacing is effective. Any atrial oversensing? No, because it would mean atrial oversensing, one atrial spike must be missing. And you see even from the very last seat, atrial pacing is extremely regular, no gap. Any undersensing, P wave with pacing after it? No. So atrial, no problem. Ventricular, the same. So if you look at this ECG, it is, I would say, an AV sequentially paced rhythm, which means atrial paced, ventricular paced. You can also say this is DDI pacing. There's nothing tracked, so DDI pacing. AV sequential pacing at 60 beats per minute. It's a long AV delay of approximately 200, I don't know how much, it's 8 times 4, 300 milliseconds, a little bit long. And then it's left axis deviation. QRS width is around 180 milliseconds, QT is around 380, and there are no intrinsic atrial or ventricular beats, no arrhythmias. So far, so good. What I want to ask you, where exactly is this lead positioned? Ventricular lead. Left or right chamber? Somebody says right chamber. How do you know this is in the right chamber? It's good that it's in the right chamber, but how do you know it? He says, but somebody said it's in the right ventricle. How do you know that it's in a right ventricle? Somebody says the ventricular paced beat looks like a left bundle bunch block. Left bundle branch block, I have learned that it's a S in V1, but then there is a large R in V6. I don't see it. I see an S in V1, 2, 3, 4, 5, 6. So the thing is, what I want to tell you, is this left bundle branch block? Yes. Yes. For left bundle branch block, the definition is only V1. So it is not exactly the same, and most so it's funny because I'm sure you all have looked at 1000 pacemaker ECGs. And obviously some of you never asked yourself the question, so this is called left bundle branch block, but only because of V1. In a natural left bundle branch block, there is typically a transition, maybe between V3, V4, but maybe also between V5, V6. And then you have at least an R. In pacemakers, if it's really in the ventricular, right ventricular apex, typically not. You can have it, but in many patients, you have an S in V1 to V6. This is normal in RV apical pacing. So why I say, is it RV apical or RVOT? Somebody said it's in RVOT. Somebody else said it's in RV apex. Why can you know for sure this is in RV apex? Yeah. Leads Roman 2 and 3. You remember? From left and right arm down to the lower part of the body. So if 2 and 3 are negative, it means the heart is stimulated from down to up, okay? So from apex to base, right? Whenever 2 and 3 are negative, it must be apical. So, RV apical lead. Very simple thing, but I think it's important to know this. Here's again Cabrera circle, 90 degrees and so forth. If the lead is here, then the vector is pointing upwards. 2 and 3 are negative. Left axis deviation. Coming to the next, is this lead in the right or left ventricle? Somebody said it's in the right ventricle. How do you know? Yeah. Now this is V1 is a deep S, like left bundle. Now look, this is nice. There's a transition between V3 and V4, like in a normal natural rhythm. So it's in the right ventricle, but something should be different, right? Somebody says in the septum, and somebody says in the outflow tract. Where's the outflow tract? Is it upper part of the heart or lower part of the heart? Okay, the outflow tract, left and right, are in the upper part. So if you pace in the outflow tract, the stimulus travels down. So 2 and 3 must be positive, and they are. Now what is really funny, one of my favorite, Haran Buri knows this, I think he will get red in his face. Lead Roman 1 is deeply negative, absolutely nothing positive. What does it mean? Yes, so if you see this in lead 1, you should be a little bit unhappy because it means that the heart, lead Roman 1, is going from the right arm to the left arm. So this patient is paced from left to right, you know. It could be in the left heart, but if you are high in the RV outflow tract, the high RV outflow tract is already on the other side of the heart, middle, more to the left. So that is why if you have a negative QRS in lead 1, you are in a high RVOT. Harimon says you are always in the septum. Unfortunately, I think this is not entirely true, but it's a very nice fairy tale, so I like also to tell it. It's a specific situation, and you see that the paced QRS is just 140 maybe. So I think here we are in the right ventricular outflow tract. This is the lead. It may be even near to the right bundle or anything, because the QRS is more narrow than in other situations. And that is my favorite lead. I implant almost always there because I have the feeling maybe it's helpful for synchrony. But again, you typically have an axis in the direction of 60 to 90 degrees, which is normal axis. Again, ECG and RV pacing, frequently you have an S in all V1 to V6. Sometimes you have an R wave in V6, depending on where you put the lead. This is all called left bundle block morphology just because of V1. So almost the last of my slides. Wow, I'm fast today. One of my favorites. This was a young, no, not young. This guy was around 60 years old. He had had heart surgery for congenital heart disease when he was 7 years old. He had a VVI pacemaker epicardially, and that device didn't work. The lead didn't work. He had exchanges every 2 years because of threshold of 5-6 volt. So I said, okay, come on. And it was single lead. He had paroxysmal atrial fibrillation. I said, let's implant a transvenous leads, dual chamber. And I asked him, do you have any documents of your operation? He said, no. The operation was 53 years ago. I called in the Düsseldorf University Hospital. They were laughing and said, well, look, these documents have long time been destroyed. I asked if his family practitioner was somewhere. The patient was laughing and saying, my family practitioner died approximately 30 years ago. So absolutely nothing. I just knew he had a heart surgery before. I put in the leads. This was the ECG result. What do you think? Where is the ventricular lead? So look at V1. Does this look entirely like a left bundle branch block? Not really, right? Lead, unfortunately, we had only lead Roman 2 during implant, and that looks like apical pacing wherever. But V1 is clearly, where are you pacing? So this is one of the largest right bundle branch blocks I know. So this must be in the left ventricle. No question about it. And in fact, it's obviously AVR is positive, so must be rather at the tip. Let's look. I think I have the X-ray. That was a very funny implantation. I was using the left arm. The first thing that happened, I was going straight across the lung. And then I found a funny vein. So obviously a persistent left-sided vena cava superior, okay. Going here, this must be the coronary sinus. So now you see here, the leads are very, very far apart from each other. The atrial lead, usually in left-sided SVCs, you only get to the lateral right atrium. But this doesn't look too bad. We go from a coronary sinus to the right atrium, and then here to the right ventricle, right? It doesn't look so bad. So like Haran said, always when you implant, take 5 seconds of time, go to LAO view. And this is PA, and this is LAO view. So we're looking from the heart tip. This is going to the most likely, in fact, somewhere upper right atrium. But here you see, here should be the septum, atrial septum, ventricular septum, and this is at the back of the heart. So this is going directly to the left ventricular apex. How? Could be. I thought I would have gone to the right atrium, I said, and then maybe there's a VSD or whatever. Here you see the knee like a tricuspid valve. So in fact, and it's funny, I'm an adult cardiologist. I don't know these funny things. I showed it to a pediatrician. He said, yes, of course, this is a typical unroofed coronary sinus. The CS has no roof. There's a short circuit to the left atrium, and this is going directly to the left atrium across the mitral valve to the left ventricular apex. And in fact, because the patient had heart failure and had Coumadin anyway, I left it because I said, wow, this is endocardial left ventricular pacing, something many people try to get by lots of difficult techniques, and we have it for free in this patient. So, and in fact, he recovered dramatically. So what I wanted to show you, LV pacing as a typically funny axis. Sometimes AVR is the most positive. And important in LV pacing, you have a giant R wave, a dominant R wave, typically beyond V2, even beyond V3. And that tells you that your lead is in the wrong chamber. If you see it in a normal implantation, just whistle a little bit, pull it back, and maybe nobody has noticed what you've been doing. So thank you very much.